Well, welcome everyone. I'm here at the World War II Museum. Welcome to Intrepid's Eye Society's Winning Strategies for Refractive IOL Patient Satisfaction. We're just really honored to be here supporting optometry, supporting all of you. Huge thanks to Fundings Land Group who put this location together at the World War II Museum here. New Orleans is, if you're wondering why this museum is here and why we're talking about World War II in New Orleans, it's actually kind of an interesting story. The Higgins industry created the LCVP. This boat here, this Higgins boat, was built here by Higgins Industries around the World War II time. And Eisenhower actually claimed that the Higgins boat is the man that won the war. So they decided to honor New Orleans with this amazing museum. And I hope you all get a little time to walk around and check things out, see what's here. Museum. And again, thank you for being here with us all. We're really excited to be here. One of many of Intrepid's goals is to further optometry, and we hope we can do that for you tonight in a fun way. Thanks to our sponsors, our Horizon Therapeutics, Johnson & Johnson Vision, and Tarsus Pharmaceuticals. Without them, we couldn't do fun things like this, and hopefully have a little fun with our education. All right, so tonight, here's our agenda. We're going to do a little introduction, a little polling, get to know you all, and then we'll go into some game. As you can see, we're kind of the Family Feud style focus feud here. A little competition in Intrepid is always welcome. I don't know if you know this about us, but we tend to be a little competitive, right, Jade?
Just a little bit, just a little bit.
So we'll have a little game, a little competition, then we'll wrap up with Q&A, audience polling, and then we'll end from there. These two are going to go at it. You guys hold on to your hats. All right, everyone. So if you can scan this QR code, take your phones out like you did in lecture all day today, and scan this QR code. We're going to have you participate in the program. So you're going to be part of the program tonight. We're a family here. So select the desired radio buttons and then click Submit. So scan the code, select the buttons, hit Submit to submit your questions. As well, you should be able to ask questions live here, and they'll pop up for me so we can interject if you have any particular questions. We'll be around afterwards as well for questions. All right, credit designation statement. The Funding Land Group is COPE-approved administrator. I'll let you read this, but there will be some COPE here as well. Here's our learning objectives. Discussing cataract surgery and IOL selection and all the things that go into how we select and how we as optometrists recommend IOLs for our patients. So we can do the best job giving our patients the best surgical experience, because who knows our patients better than optometrists. And our disclosure policy is well here. Here's our financial disclosures. I wish mine was longer than Schweitzer's. That's a competitive goal I have here.
Again, a little competitive.
All right, and this is the note about obtaining credit. You must have viewed the course in its entirety and established by COPE, receive an email and a link to obtain credit within 24 hours of the program's completion. So polling question number 1. Again, that QR code's there if you missed it or you closed the window, so just jump back in. So where do you practice? The only real area of the country, the Midwest, specifically the upper Midwest, aka God's country.
Woo. Just careful where you're at, Jake.
The Northeast, the Deep South,
Amen.
West, Canada, or other. Just say amen. Mark Schaefer saying yeah. All right, so let's see what we have here. So, pretty diverse group, a little home field advantage for the South. A little home field advantage, which we love to see. I like to see that diversity in the group here. How many years have you been practicing outside of school and training? So how many years have you been out of the books? When did you last say goodbye to a board exam? All right. Yeah, this morning. We had some freshies. That's good. We like it. We got a little diversity there as well. How many cataract surgery procedures do you refer out or co-manage each week? Like what percentage of your clinic time is spent referring out and or co-managing postoperative cataract surgeries? So how much time do you spend with that perioperative cataract surgery time? Good, little bell curve there. A couple over 40, look at that. 5 people over 40% of their day spent with cataract surgery. That's pretty impressive. And polling question number 4, how confident are you in discussing the outcome expectations of refractive IOL patients, because all IOL patients are refractive IOL patients, and identifying the impact of unhappy refractive IOL patients on an optometric co-managing practice? We're testing your confidence. We want to see how confident you are now, and then hopefully after our discussion we'll talk about some of this, and hopefully we're more confident. How confident are you in defining best practices for diagnosing comorbid conditions in patients considering refractive IOLs? This includes lid management. How confident are you with regards to the best practices of making sure there's not more than a cataract? Because one patient can have multiple diagnoses. Great, pretty bell curves there. How confident are you in identifying and applying best practices for interacting with refractive IOL patients and co-managing the surgeries before and after treatment? How confident are you guys? Well, you're a confident crew. You hang out with good people like us, you'll be a very, very confident crew. So another good bell curve there. All right. So we're going to dive into this now. I hope you're all ready. We've got team 1. Team 1, the Fighting Irises. The Fighting Irises, led here by Dr. Selena McGee. And team 2, the Jazz Cats, or should I say, the Jazz Cataracts, led here by their leader, the leader of the pack, Dr. Nate Lighthizer. So,
Oklahoma.
Here we go.
So I was going to say, this is kind of the Battle of Oklahoma here. Is this a Oklahoma State versus Oklahoma battle, or East versus West? What is it? All right. So as you're aware, we're going to read you a question. We polled some people. And then we got some buzzers up here. We're going to see how these guys are as far as competition. Round 1. Nearly 300 optometrists participated in the 2023 Optometric Trends Discovery Group survey. They were asked to name the most important post-surgical concerns that influence their lens recommendations when selecting presbyopia-correcting IOLs. She's fast. What are they?
I want the best vision possible at every working distance.
So can I see the best possible working distance at all vision ranges? Answer number 1, right off the bat. That is tough to compete with. That is tough to compete with. 50 answers for maximizing visual acuity at all ranges. Awesome work, Selena. Do you want to play or do you want to pass?
Oh, we're going to play.
Never a doubt. All right, so why don't you dive into this, maximizing visual acuity at all ranges, Selena?
All right, the reason that I said that is because our patients want, most of the time, the least spectacle dependence as possible, right? And it's very important for us to understand how the patient uses their vision every day and what their expectations are so that we can match the technology to what the patient desires. And we have the technology available to us now to have patients see great at distance, intermediate, and up close. And it just depends on if they have a comorbidity, it depends on ocular surface, and again, what the patient's expectations are. You know, there's certain patients that we certainly don't want to put a multifocal in, just honestly because of patient expectations. And so often I will share with my surgeon, do not put a trifocal lens in this patient, because remember, we all have the relationship with our patients, right? We understand these patients, we've worked with them for typically sometimes many years, and when you have that kind of history, it's very difficult for your surgeon to get that information in 7 to 10 minutes that we all have, right? So for us to maximize that visual acuity at all ranges, we just need to understand what the patient truly desires, and then we can marry whether it's a monofocal, whether it's an enhanced range, whether it's an extended depth of focus, or a multifocal IOL and alongside a trifocal IOL. So we have the technology, it's just putting all of that together, screening the patient best, which we'll talk about more. But that's how we're able to meet expectations, set expectations, talk about explanations before surgery, not excuses after surgery.
Yeah, definitely. So we have kind of these three big ranges. We categorize vision in distance, intermediate, and near. You know, really, we have to remember that this is a spectrum, right? Different people do different things at different distances and have different passions. Where do you see, like, your patients gravitating more now over time? Do you see them really concerned more about their near, their intermediate, their distance? Do they?
It really does vary, and people are still really active. You know, I have just one person that comes to mind. I have a very active photographer, and he wanted great distance because he's traveling the world, and he wanted good intermediate because that's kind of where he lived, and he was very particular. So a light adjustable lens for him was perfect. It just really depends on the patient. I had a patient last week actually that we were having a conversation about what our plan was for their surgery, and she said, you know, I'm going to retire in 3 months. So it was very important for us to dive into that because we don't want to set her distance for the next 3 months. We want to set her distance for the rest of her life. So it's not only having that conversation today, it's exploring what the patient desires, you know, for the next
for the future.
however many years.
Yeah, as I enter presbyopia, I'm realizing, like, oh yeah, this stuff is kind of important, right? And it's really interesting, you know, your arms get a little longer, but you're kind of like, at the same time, like, yeah, intermediate is great, but it's kind of nice to hold things up here sometimes too, right? And so we have to discover that with our patients. What do they want? What do they need? Do they mind holding things out here? Do they want to hold it up here? What are they up to? And everyone's an individual, that's for sure. All right, so let's get back to the game here. Fighting irises. Are you ready to rumble?
I think I have a good guess, a great guess.
Is it a guess or do you know, Jay?
Do you want to re-ask the question?
So, what are the most important post-surgical concerns that influence optometrist lens recommendations when selecting presbyopia-correcting IOLs?
All right, our answer, I think, would be to minimize the glare, to minimize the dysphotopsia.
Minimizing, can I see minimizing dysphotopsia? All right, she snuck it in there. Answer number 5, minimizing dysphotopsia. So tell me about dysphotopsia. Is it like a disco light? Is that what we're talking about here?
Not exactly. So in a cataract refractive surgery in our clinic, the key to minimizing dysphotopsia, of course, in addition to choosing the correct lens, but setting this patient expectations. This is the last bullet point on this slide, but arguably that's the most crucial in helping to manage exactly what they're hoping to get out of cataract surgery. So minimizing the dysphotopsia is also minimizing the glare, the starbursts, and the halos, and enhancing the visual comfort, and also impacting the overall quality of their distance visual acuity. The interesting thing about extended or enhanced monofocal IOLs is it does have the opportunity to provide distance image quality that's enhanced in low lighting. So I like to take all of these into considerations whenever I'm choosing a lens to help minimize dysphotopsia.
That's great. Yeah, we want to make things better, right? Patients are coming in with a cataract sometimes, sometimes not with refractive lens exchanges, but can we make things better than they were before, and what do the patients need to know about, and how to set those expectations. Expectations is really, really so critical when letting the patient know what they want to come out of.
Well, and remember too that it's not only our multifocal lenses. Patients can get dysphotopsia with monofocal lenses, and it's typically negative dysphotopsia, right? So it's the absence of light instead of extra light, which is positive dysphotopsia like glare, halo, and starburst. So those negative dysphotopsias, patients often come in and say, I have this like weird like little dark arc over here off to the side, and they're super concerned about it because it's new and different. And it's just that our brain has to get used to that, and that's different for everybody. But if we set that expectation and we reassure patients, those things go a long way in having those conversations.
Yep. Reassure them, let them know it'll get better. But yes, both those negative and positive dysphotopsias can be present as well. Other things can cause dysphotopsias too, right? We have a whole visual system. It's not always the lens that can cause dysphotopsia, and we're going to talk about that a little bit more. But I want us to get Justin up here. So Justin, your turn. Don't let your team down now, or they'll be fighting you. What's the most common, most important post-surgical concern when recommending and selecting presbyopia-correcting IOLs?
There are not enough good lenses out there.
There are not enough good lenses up there?
Good answer.
Oh, Justin. So, are there enough good lenses out there? I think if we think about the technology and how it's changed and advanced with lenses, even over the last couple years, we're generations forward. We're not using the iPhone 1 anymore. We're on the iPhone 15, 16? What are we on? 15? I have a 16. So the diverse toric and multifocal optical designs allow us to correct different things for different people. We have options. We have a lot of great options. What do you think about that, Justin?
We have a ton of good options. I mean, you look at what we have. We have lenses that can correct for astigmatism. We have adjustable lenses. We have multifocal lenses. We have trifocal lenses. I think the key, which has been said over and over again, is you got to make sure you put it in the right eye. And so you got to have a good ocular surface. You can't have retinal pathology. And then education, which we're going to get into a little bit later,
Yep.
is so crucial with these. So there's plenty of lenses, and these lenses work.
Yep.
They all work. When they don't work, it's because they're put in the wrong type of eye.
Yeah. Yeah, we're definitely pairing that lens with the patient and the eye as a whole. So we have a lot of great options. We even have monofocal lenses that are starting to improve things and give us more depth of focus and crisper vision than we've ever had before. So lots of great options, whether it be multifocal, depth of focus, distance only, toric, astigmatism, or combining that astigmatism with some of our options out there. Excellent. Well, your team still has 4 on the board, 1 strike gone. Back to Selena McGee, who hit it out of the park first time. Selena, back to you. What lens recommendations when selecting a presbyopia correcting IOLs?
Okay, Jake, here we go. You ready?
I was born ready.
I think it's minimizing medical complications.
Can I see minimizing medical problems? All right, number 3, she's hitting it out of the park. Minimizing medical complications. Complications are part of surgery. I've never seen a perfect surgery.
So we're the leading part of this conversation, right? These patients are sitting in our chairs. We're sending them to surgical consultation. And one of the key pieces is making sure their ocular surface is optimized. That's one place. And starting with the eyelids and working our way to the cornea all the way to the back part of the eye, looking for retinal pathology as well. But let's talk about the anterior part first. And I love this Ascaris, preoperative OSD algorithm that they spent about 3 years doing this and putting this together. And it looks really complicated, and so I'm going to make it really simple. It's 5 things. It's look, lift, push, pull, and vital dye. And what we mean by that is look at the lids. Make sure the patient looks down. When you're looking at the base of the eyelashes and what's happening with the eyelids there, you're going to uncover things like Demodex blepharitis. If you see collarettes, that's pathognomonic for Demodex. That has to be cleaned up before the patient gets to the surgery center, certainly before they get into the OR. So starting with the lids, that's one. So looking and then lifting. And so often patients will have lid disorders or even sleep apnea and they have floppy eyelids. That's another place. And when we have issues there, we don't want to miss systemic issues, right? And then pulling and pushing. So pulling on the lids, pushing on the lids, especially for meibomian gland dysfunction. Those are all things that we need to address before we send a patient for a surgical consult, because we want that ocular surface optimized. When we don't have a good ocular surface in place, we don't get good pre-op calculations, and it can skew it as much as 3 diopters. So when you have a patient who has the expectation, no matter what kind of implant they're having, that they're gonna have less spectacle dependence, or they have a certain expectation of where they want their working distance to be, and we miss that by even a quarter, that can make patients unhappy, certainly by 3 diopters, right? So it's super important for us to maximize that ocular surface. And of course, we're gonna treat the patient with, pre-op steroids, pre-op antibiotics to minimize the other complications. But we always do an OCT as well. I wanna make sure that I don't see anything in the macula that would cause us a problem, or change a solution depending on the lens if we have issues in the macula as well.
Yep. Look, lift, pull, push. That's great explanation there, Selena. I love it. All right, Jade, holding it up her end of the deal here. Let's see.
Sure.
Tell me what lens recommendation what concerns the influence optometrist lens recommendations when selecting presbyopic correcting IOLs? Jade Coates.
How about buyer's remorse and patients regretting paying so much for lens?
Can I see patients regret paying so much money for these lenses? Oh, strike two. So they got 2 strikes over here. Come on, Jazz Cats, get it together. Let's see what they got, okay? I want a good answer. All right, do patients regret paying so much money for these lenses? Really, the point here is we get to offer our options to our patients, and they really have some say in this matter as well, right? So we want to educate our patients fully, just like we tell them the risks, benefits, alternatives to their surgery. We need to tell them the options that are available to them and let them decide what's affordable for them, what's not affordable. Maybe this is really what they've been saving up for. Maybe this is a priority for them, and they've been saving their whole life for this, and this is their one shot at cataract surgery. They want to do their best job. Any other thoughts on that, Jade?
Everything that, you just mentioned, you cannot judge a book by the cover, and I've been being in a practice that does a lot of premium lens implants. Everyone gets the exact same speech, and we start at the top, the best of the best, and we kind of work our way down if necessary. So I do find it very important to treat everyone the same and just let them know all of their options, regardless of price, and have them make that decision.
Yeah, we have to remove some bias. That's a great point. All right, what are the most important post-surgical concerns that influence optometrist lens recommendations when selecting presbyopia correcting IOLs? Justin Schweitzer, do not let this go to 3 strikes.
Can't go 2 here.
The Twins had enough of those yesterday night.
You had to bring that up? Leave that out of this. Maximizing visual quality, specifically contrast.
Can I see maximizing visual quality, especially contrast?
Yeah, that's right.
All right, they're alive. They're staying alive. They're staying alive. Tell me about maximizing visual quality, Justin.
Yeah, so what you're going to see on the slide deck here is, number 1, a bunch of references. If you want to do some light reading tonight after having a few glasses of wine, that will put you to sleep to read those 4 different studies on the lower bottom part there. But really, we're looking at the improvement in contrast sensitivity with a bunch of different IOLs. And when we think about all the IOLs, we have trifocal IOLs, we have Panoptics, we have Synergize, which is kind of a multifocal EDOF type of lens. We have extended depth of focus lenses, we have Symphony, we have Vivity, we have Eye Enhance. All these types of lenses, when you look at the various contrast sensitivity charts, have improved what they do from a contrast sensitivity standpoint. We don't have to worry about it like we did in the past. Older technology, older multifocal technologies, unfortunately, there were issues with contrast sensitivity, and it affected the way that our patients would see on a daily basis, and we had to educate that way. The technology we have now is so much better. Is it perfect? No, but it is so much better from a visual quality and contrast sensitivity aspect.
Yeah, this isn't your your grandfather's IOL anymore, is it? The technology we see in optics across the spectrum, whether it's glasses, contacts, of course IOL technology is improving. We're better understanding multifocality, toricity. We're doing a better job. And so this is not your grandfather's IOL anymore, is it? Great explanation, Justin. Great answer. Way to keep your team alive. Still 2 strikes over there for the Jazz Cats. All right, back to Selena McGee, who's been hitting it out of the park here. Selena, what's the most important post-surgical concerns that influence optometrist lens recommendations when selecting presbyopia-correcting IOLs?
You know, I worry sometimes when I marry a technology to a patient that they're not going to like it, and then we have to worry about explantation rates. So that's going to be my answer.
Explantation rates. Oh. All right, all right.
I'm not all right. Sorry.
Huddle up here. We've got 3 strikes. We've got an opportunity to steal. Jazz Cats. How common is explantation? I think we just talked a little bit about, focusing on the technology and how much improvements we've seen. Really, this is, with our technologies today, we usually don't get to a point where we need to explant an IOL. One big thing we want to make sure is if that might be a concern, we don't want to do an early YAG procedure if we're feeling like that might be even a possibility down the road, that we haven't completely convinced this patient that things are good, or or you're not convinced that things are good, and they might be heading down the wrong direction. Any other comments on explantation, Selena?
I do have a comment. So one of my favorite questions, because if they do have a PCO, how do you know if it's the PCO or is it truly the lens design that is the issue? And so on those patients, if you ask, was your vision ever clear after surgery? Was there ever a moment that you appreciated your vision and liked it? And if they say yes, and now they're frustrated, that's more likely PCO. And so that's a different conversation. But if it was like that from day one, then that truly may be one of those rare cases where we just have not neuroadapted to the lens. Now remember also that when we talk to patients about IOLs and how they adapt, this is the same brain but a new image, and it can take 6 to 12 months for them to fully appreciate their vision because the visual pathways actually have to reform. The older the patient is, the longer that takes, and so that neuroplasticity matters, and talking to patients about that beforehand is very important when we're thinking about this conversation around IOLs.
That's great. Neuroadaptation being an important part, letting the patient understand that their brain's going to help them use these lenses better with time. That's excellent. All right, so we've got a team answer over here. We've got a chance to steal for the Jazz Cats.
Ready to steal.
Are you ready to steal? Carolyn, what is your answer?
Lucky tonight. Minimizing residual refractive.
Can I see? Good answer. Good answer. Good answer. Can I see minimizing refractive error for the win? Ooh. Congratulations, congratulations. Jazz Cats, Jazz Cataracts. Tell me more about minimizing residual refractive error, Carolyn.
Absolutely. So in order to minimize residual refractive error, it's really important to get accurate and precise preoperative measurements. And that may require dealing with some corneal surface disease initially first, like EBMD or dry eye, in order to get those good measurements. In addition, a light adjustable IOL may be another good option to help minimize residual refractive error.
Yeah, that's a great point. If somebody's on the fence or we're not sure what they're really telling us about their eyes or what they want their vision to be, hindsight is 20/20 sometimes, and being able to adjust things afterwards is a great option. So, but our biometry has improved as well as our other technologies. So that was a great game, a great challenge here. So, maximizing visual acuity is all range, maximizing the quality of that vision across the spectrum of their vision, minimizing medical complications, avoiding trouble with our surgeries, minimizing residual refractive error, and minimizing dysphotopsias. All things we want to talk to our patients about, things that we want to minimize or avoid, important priorities for the optometrist when discussing IOL technologies with our patients. Congratulations Jazz Cats, you have been awarded 150 points.
Right.
Fighting Iris, 0 points. It's early in the game. We've got time for more. All right, Jade Coates and Mark Schaefer.
Let's get loud out there. Come on, let's make some noise out there. Come on. Come on, Musco. I want to hear you out there.
I feel slighted.
Yeah, they're going down.
All right, we've got our second players up here. Mark Schaefer, Jade Coates. Any predictions?
She's going down.
Listen here, Bowtie.
All right. We asked 100 optometrists, what is the most critical comorbid condition? What is the most critical comorbid condition to screen patients?
I'm ready.
Considering your reaction, you seem ready.
Yeah, it's ocular surface disease, please. Good answer.
Can I see ocular surface disease, please? That is the quickest trigger pull in a Focus Feud history.
You can call me Kid, because we playing.
Kid and play. All right, so ocular surface disease, Jazz Cataracts decide to play. I'm still amazed in how quick you were with that. I wonder if you're that quick on the football field or the basketball court.
No, none of those places, right? Look at me. I'm an athlete. So the beauty of going after Selena is that she gets to say everything so beautifully, and then I get to follow up with, yeah, let's do that again, right? So ocular surface disease is so important when we talk about cataract surgery, and especially premium IOLs when you have that discussion. Again, our job is to co-manage these patients. There is nothing worse than going through everything with the patient, sending them on for cataract surgery, and then having to wait for someone else to clear up the surface that we could have done in our offices. And I think it's really important for us to do this. I like 3s better than 2s, so it's the 3L, so listening to the patient, right? Understanding what's going on with their ocular surface, their symptomatology. So listening to them, listening to their medical history. Do we have any masqueraders or any other conditions that may be causing underlying autoimmune issues and systemic diseases? We're still gonna lift, we're still gonna look. The pushing and the pulling, we still want to look at meibomian gland function. We want to make sure that everything is working well and properly to ensure, again, good biometrics. We can see up to 3 doctors of astigmatism correction with bad ocular surface disease. So we know that, again, you're paying money out of pocket. That's when you have the moments where this is where I regret paying for the lenses because we didn't do a good enough job of preoperatively taking care of these patients. And I like when everything makes sense, so you'll see podiagnostic testing because it's 3 L's and 3 P's, and diagnostic testing does not start with a P, but we still want to do all of these. You got to make it make sense, right? Make it make sense. We want to make sure that we're doing all of these testing, again, to confirm that everything is going on. So everything from the eyelashes, as simple as looking down in order for us to make sure there's no Demodex, no blepharitis that may cause postoperative complications, all the way through the ocular surface. And again, it's a really easy mnemonic to remember. Listen, lift, look, push, pull, podiagnostic testing.
Podiagnostic. I'm learning new words. My vernacular is expanding exponentially
In
here
the South,
today.
we call that podiagnostic testing.
It's a new Southern accent I've never heard before. I love this. I love how you expanded it and made it your own. God knows you will. But I also love how we rule out the comorbid conditions or masqueraders that could occur here. We know that hyperosmolarity in ocular surface disease can mimic the blur that we have with a cataract. Sometimes even up to a grade 2 or grade 3 cataract could be equal to the just having hyperosmolar state and having ocular surface disease. So treating that ocular surface disease is definitely a priority. Mark nailed it. We got to look, listen, push, pull. Make sure we're not
Podiagnostic testing.
Podiagnostic testing to make sure that the osmolarity is normal and other testing. Also ruling out things like recurrent corneal erosions or ABMD that might cause some irregular astigmatism that might throw our patients' biometries off. So we have to rule out those things, making sure that surface is clean and smooth, everything's looking perfect. How do you know when a patient, so you have a patient,
Yep.
and we know from a lot of Bill Tratler's work, like 80% of patients with going for cataract surgery are gonna have ocular surface disease, Mark.
Yes.
How do you know after they enter your world of ocular surface disease therapy,
Yep.
how do you know when they are ready for surgery? When do we send the patients to the surgeons? Because we're all good optometrists trying to make our surgeons look good, treating things that we can treat before we send them for the surgical part of their ocular health. How do you know when it's time?
I think it starts inside out, right? So we want to have a clear central cornea. That's the biggest thing when you're talking about visual outcomes, is that central cornea. So if I've stabilized the central cornea, I know that that surface is looking good, staining is looking better, tear film breakup time is looking better. If I'm seeing improvement, and generally we're doing this sooner rather than later, the patient's very motivated, so they're more likely to be compliant with medications, which is always a challenge. Once we see stability, once we see that tear film working the way that it should, that's when I know it's time, and the patient can feel improvement, and even sometimes we get better vision just by treating the ocular surface, and now they're even more ready for cataract surgery.
Yeah, that was a great answer. Yeah. But the answer was I can't even do it.
Try again, Jake. It's podiagnostic testing.
Diagnostic testing was the answer. Oh no, but other things we have to think about, right? Ocular surface disease has a lot of symptoms, it's signs and symptoms of ocular surface disease. And sometimes symptoms of ocular surface disease aren't ocular surface disease, but maybe something lying deeper. One of the things we know that lies deeper and mimics ocular surface disease, and is actually found concomitantly, is thyroid eye disease. As we're advancing our technologies and therapies for our patients, we as optometrists need to be more aggressive with diagnosing and finding thyroid eye disease early so we can intervene better to make sure we're making our ocular plastic, our neuro-ophthalmology colleagues look better as well. So all these patients with thyroid eye disease, this is just a graph here showing that at thyroid eye disease diagnosis, what symptoms were the patients reporting, and then during the chronic phase, what symptoms were they noticing? If you look at those top, dryness, grittiness, pain, light sensitivity, watery eyes, eyelid inflammation, eye inflammation, itching. Itching is a huge one up there. I think if you saw that stuff, you'd say, oh, that patient belongs in my ocular surface disease clinic. Like, put them in the dry eye clinic. When actually it was their thyroid eye disease that was driving the ocular inflammation that's probably leading to some ocular surface disease, but they had a bigger fish to fry. They had a bigger thing going on underneath that was smoking and smoldering this whole time. So keep your spidey sense open. Keep aware for other signs that might not just be just dry eye. I hate to say that, but not just dry eye. All right. Let's get another answer here. So Nate Lighthizer, what is the most critical comorbid condition to screen for in patients considering refractive IOLs?
I think we need to give some love to the back of the eye for a little bit. We've had a lot of front of the eye focus. It's time for back of the eye. How about some glaucoma?
Nate Lighthizer says glaucoma? Weird. Can I see glaucoma?
Yes.
Oh, number 2 answer. Nate Lighthizer with the glaucoma. All right, screening for glaucoma. Tell me more about screening for glaucoma in the perioperative patient, Nate.
Yeah, they gave me 2 minutes on glaucoma and 1 slide. So this is, I figured this was the best slide. Glaucoma is truly a puzzle. You guys know that we have no one perfect test in glaucoma. We've got to add together structure and function. We all do that very, very well. Don't forget your visual field, your OCT, against structure and function. So very quickly going through this, corneal thickness, we know that's a risk factor. We're not going to correct IOPs based on that, but the Oates study, among others, said corneal thickness. Thick corneas makes me feel a little bit better. Thin corneas, not quite as much. Corneal hysteresis is something that we utilize a lot in our glaucoma clinic, and it is a big risk factor for glaucoma progression. Your patient that has a low corneal hysteresis in the 8s, in the 7s, in the 6s, that is telling you that the eye is not handling those stresses, that shock absorbing properties are not as good in that eye. So low corneal hysteresis, more likely to progress based on numerous studies out there. So look at the corneal thickness, look at corneal hysteresis, IOP. We all check IOP, Goldman, probably the standard, but study after study shows that we need to check the IOP, and it's our main modifiable risk factor that we have. We know that from OATS, from AEGIS, all the other studies of we have to lower the pressure. Set a target pressure in your patients. All of us are going to highly recommend you set a target pressure. What is it set based on? Based on severity of disease. We stage glaucoma based on visual field criteria, among other things. And generally speaking, the target pressure should be set. Mild glaucoma. How much do you guys reduce the pressure in mild glaucoma? 25 to 30%. From baseline is where we'd like to see mild glaucoma. Moderate glaucoma, we're going to reduce it maybe 35+% and no higher than 18. And you get into severe glaucoma, and we're going to be no higher than 15 and ideally 10 to 12. So based on severity of disease, how much we lower pressure, you've got to set target pressure. Again, it's not set in stone. You can move it one way or the other. There are exceptions to the rules, but set a target pressure. Visual fields. Patients love visual fields. I mean, they just want to do them again and again and again, but we know we got to have that data. Repeat the visual fields, get more data. The American Glaucoma Society, the American Academy of Ophthalmology has given us guidelines on staging based on visual field criteria. What's mild glaucoma? Optic nerve abnormalities consistent with glaucoma, and really it's pre-parametric based on visual fields. There's no visual field defects, or they have them on SWAP or FDT. That's mild glaucoma. Again, pretty much pre-parametric. Moderate glaucoma, now you've got optic nerve head abnormalities consistent with glaucoma, and you've got visual field defects in one hemifield and not within 5 degrees of fixation. Severe glaucoma, you again have optic nerve abnormalities consistent with glaucoma, and you have got visual field defects in either both hemifields or within 5 degrees of fixation. So stage mild, moderate, severe based on visual field, OCT, set your target pressure. We've got a variety of tests because we have no one perfect test. Don't forget family history, and obviously don't forget your OCT. Ganglion cell analysis, retinal nerve fiber layer, add up the picture for diagnosis. We can't miss glaucoma when considering these patients with refractive IOLs.
It's
You're looking for a plethora of podiagnostic tests, right?
Plethora of podiagnostic tests, correct.
Use your cataract surgery also to help in the glaucoma patient. Often I will refer a patient for cataract surgery sooner when I need better glaucoma management, because just the surgery itself can lower their IOP 2 to 4 points. When they're in there, they can do, a combined procedure. So there's opportunities there in that cataract patient as well to better manage their glaucoma.
Yeah, that's a great point, Selena, that we have an opportunity to correct vision with refractive error. We also have an opportunity to lower IOP. Nate, when you see a lot of our refractive patients have had LASIK, right? So they've had LASIK, they're myopic, had LASIK. As they continue this life journey, they end up with a cataract, and they are some of the more motivated patients to look into further technology to help their vision as they were when they had refractive surgery. Do you look at post-LASIK patients differently that have glaucoma?
So I do. You're obviously going to, when it comes to the cornea, you're going to have to not factor that in as much as you would, but I look at the cornea and I will factor that in to some degree, especially when making decisions for these IOLs, the glares, the halos that we talked about before can be enhanced when that cornea has that LASIK, so I factor that in, yes.
Yeah.
I would say too, just real quickly, the IOL technologies, I mentioned it earlier with contrast sensitivity being better, we're now putting more of these IOLs in patients that have glaucoma than ever before because we're not worried as much about losing that visual quality. Glaucoma decreases contrast sensitivity in some more advanced states, but a lot of these implants can still be utilized in patients that have mild glaucomas, as in a central field defect, and I think many of us have utilized those in that manner. So I wouldn't remove that from the arsenal for some of these patients that want some independence from their glasses or contacts.
Back to his answer about contrast sensitivity, that we're seeing nerve changes that are affecting our visual quality, but the lens technologies have met that challenge, is what Justin's saying, but you don't get to use your answer twice. I just want to remind you.
No points for that?
One extra credit point. All right, so glaucoma. Great discussion. Let's move on down the line. Let's get back to the game here. What is the most critical comorbid condition to screen for in patients considering refractive IOLs? Carolyn.
I'm going to go with the favorite thing in my career, which is retinal diseases.
Retinal
Good answer,
diseases.
good answer,
Can I see
yeah.
retinal diseases?
Now I know why.
Yes. Woo! All right, retinal diseases. I guess there are diseases in other places besides the cornea, allegedly. I'm learning that's what Academy is all about.
Like a dust cover for the retina. I only ever notice it when I can't see the retina, and I look back and I'm like, what's all this SPK stuff going on? Anyway, I first want to talk about how we can diagnose subtle retinal diseases and what tools we have available to assist us with that. And OCT has absolutely revolutionized retinal disease diagnosis and management because we get such high resolution details of the retina, we can visualize individual layers and identify very subtle pathologies such as epiretinal membranes, old central serous chorioretinopathy. Also keep in mind that diabetic retinopathy and macular degeneration are progressive conditions and certainly need to be considered when you're selecting an IOL for these types of patients. Next slide, please. Some IOL design implications that you may want to consider would be achromatic technology or light filter technology, but really you want to maximize visual resolution as well as light transmission and image contrast if at all possible. So a monofocal lens would probably be your best option for a patient that has any degree of macular disease.
That's awesome. Yeah, definitely in our practice, OCT before any cataract surgery, just to screen for things, look for things that we can't see because we've got technology that can see some things that we can't see, and it's really revolutionized our understanding of retina. All right, you guys are doing good. 2 for 2. Back to Captain. 3 for 3. So I left the other one out the side. So 3 for 3. Back to Captain Mark Schaefer here. What is the most critical comorbid condition to screen for in patients when considering refractive IOLs?
So like I hate inflammation. So I'm gonna do inflammation right by where the lens is. Let's go with uveitis.
Uveitis. Uveitis. Can I see uveitis? Oh. He is
1 for 3. 1 for 3.
All right, uveitis. Yeah, uveitis. Less common and not directly related to factors typically considered with refractive IOL implantation. More at our post-operative appointments, we're assessing inflammation in the anterior chamber, making sure that's not a sign of surgical complications. If that patient has a uveitis pre-op, what do, Mark?
Treat it. Right, good answer, right? Good answer.
That's what I like to see, a medically minded optometrist treating uveitis. That's what I like to see.
Steroid, heavy dosage on the front end, so treating, if I'm doing prednisolone acetate, it's at least every 2 hours in that eye. If I can get difluprednate, that's 4 times a day. And then tapering once I see resolution of cells and tapering appropriately, not stopping medication too quickly.
It's awesome. Yeah, give it a good kick in the pants, right? All right, 1 strike for the Jazz Cats. Back to Nate. What is the most critical comorbid condition screened for patients considering refractive IOLs, Nate Lighthizer?
So I talked about the back of the eye. I want to give love to the front of the eye as well. Let's not forget corneal abnormalities, irregularities, things like neurotrophic keratitis.
Can I see corneal abnormalities, including neurotrophic keratitis? Hey! There he is. 20 points for answer 4. Excellent answer, Nate.
Okay, let's talk about some corneal abnormalities in NK. So when you're looking at ocular surface, and we've talked a lot about managing and optimizing that ocular surface, we certainly don't want to miss an NK patient because also cataract surgery itself can cause neurotrophic keratitis. So some things to incorporate into our clinics. When you have a recalcitrant cornea or you have a pattern of staining that looks different, what's an easy way to test that cornea? Corneal sensitivity testing, right? Super simple. You can have a Cochet-Bonnet aesthesiometer. Anybody have one of those? Ooh, one, I love it. I just like to say that word. Jake has one, of course he does. But I use dental floss. You can use a corneal wisp. But the key is actually testing for corneal sensitivity. And I had underutilized this early in my career, and this is a great diagnostic tool that cost us nothing. And when you're doing corneal sensitivity testing, you're not just testing the central raphe of the cornea, you're gonna test at 6, 9, 12, 3, and then the center part of the cornea, because you'll have different parts of the cornea that have different amounts of sensation. So this is just an important piece to utilizing. Remember the look, lift, push, pull. I like the 2 L's, 2 P's, not Mark's, whatever that was. Flip diagnostics.
Put diagnostics.
Put diagnostics.
That's the only thing people are going to remember tonight.
Is corneal staining. And when you see a patient that has corneal staining and you ask about symptoms and they're asymptomatic, there's a big clue on someone that you should perform corneal sensitivity testing on. So certainly screening beforehand, but I have had many patients after cataract surgery that wound up with, and other surgeries, glaucoma surgery, retina surgery, that cause neurotrophic keratitis. And so managing that patient not as a dry eye patient is very important.
Yeah, I see a lot of that too after mostly those posterior segment surgeries, you know. You can poke a cornea, you can't poke a retina, right? Good, good, good. Here we go. So what are we at? We got one left on the board. Carolyn Major. What is the most critical comorbid condition to screen for in patients considering refractive IOLs?
I'm gonna go with diabetes.
Diabetes.
I like it.
Well,
Diabetes,
down
yeah.
here with all this good southern food, can I see sweet tea and diabetes? Oh, second strike. Second strike. Fighting irises, you're still alive. All right. Tell me about diabetes, Carolyn.
You should look for it and ask for it in your history section. Certainly, we know that about 1/3 of adults with diabetes do have diabetic retinopathy, and it's really important to screen for when you're considering doing an IOL, because you want to maximize the visual acuity and visual quality if at all possible.
Right. Yeah. And they're probably at higher risk. They have leaky vessels, right? So they're higher risk for some complications afterwards. What kind of sort of things do you worry about more in post-operative cataract surgery patient with diabetes?
Certainly macular edema.
Yep, that macula, I guess it's important.
And refractive. Don't forget about refractive changes too from diabetic patients. So even if we have atypical blood sugar swings or A1Cs, we can see refractive shifts that are then going to change patients and their post-operative outcomes.
Yep, and probably patients that are getting cataracts earlier too, so something to think about there. All right, back to the Jazz Cats. Can they seal the deal? Can they make it stick? One answer left. Mark Schaefer.
All right.
What is the most critical comorbid condition to screen for in patients considering refractive IOLs?
No pressure.
There came a time, yeah, always pressure. There came a time where it was like, if you didn't understand or something was on boards and it was like, okay, this is an option, just pick it, right? So I'm going to go there. We're going to go with trachoma.
Trachoma?
What? If it's on boards, it's there.
Trachoma. Okay, trachoma. Can I
me,
see
trachoma.
trachoma? Oh. Well, all right. Chlamydia trachomatis causing an ocular infection, which can then lead to entropion, which can beat up the cornea pretty bad, cause scarring, ulceration, perforation of the cornea, is the leading cause of infectious blindness in the world, so we can give him that. And he is in New Orleans, so I can see how he went down the road of chlamydia, but not really something we worry about too much here. But as a little redemption, Mark, what is the most common infectious cause of blindness in the United States?
Ooh, it's something we all have, right? Rhymes with schmerpies, right? Is it herpes? Is it herpes?
Can I see herpes? No, it's not. We're not playing the game here. But yes, herpetic eye disease, leading cause of infectious blindness in the United States. Way to redeem yourself, Mark. I really appreciate your dedication to herpes and chlamydia. All right, we've huddled up here. There was a little distraction there for the Fighting Irish, but have we huddled up?
Oh, yeah.
You guys got it? You think you got it? You got?
We got it. Ready?
Team answer.
The most
critical comorbid condition, Demodex blepharitis.
Can I see Demodex blepharitis? Woo! Oh, fighting irises for the steal. Let's give them a round of applause.
Boom.
All right, 1-to-1 here. Demodex blepharitis. Tell me about Demodex blepharitis, Jade Coates.
So just what you want to see right after I'm glad you're done eating for the most part, but this is the most common echoparasite that lives on humans. And what we unfortunately commonly see in our cataract refractive evaluations is that entirely too many patients at the pre-op have this. This is a big problem, but thank goodness nowadays there is a treatment for this. And so this is really exciting times, because how do we find this? Simply by starting our exam looking down. And so collarettes are the main thing that we're looking for. They're the pathognomonic sign of Demodex blepharitis. And it truly has been shocking, simply upon no extra tools, just having this slit lamp, essentially, which is arguably necessary for an evaluation in the first place. Having them look down and seeing those collarettes has been
Eye-opening? Would you say it's been eye-opening?
I was going to say that. It's been eye-opening. But it's been eye-opening for me, but also the patients, because we know, unfortunately, that Demodex blepharitis can affect the outcomes of our surgeries. And so in our clinic, we focus on a lot of premium lens implants, and they pay very good money, extra money, versus a standard lens implant to have these extra additional benefits. And so whenever we're selling premium lens implants, but we're neglecting Demodex blepharitis, we're not going to have the best outcome that we could have had. So in our clinic, and in everyone's clinic, everyone should be looking at this, because it's very easy to identify, and now we do have a treatment for this.
Awesome discussion on Demodex blepharitis, expanding our understanding of the eye, the biome, everywhere we're taken care of. And as we learn more and expand our options, we have to raise our bar and raise our level of care for our patients. Again, in summary, a great round, both teams. Let's give them a round of applause. It's important to utilize IOL materials that optimize visual quality using an achromatic technology and light filters in our lens technologies to help give our patients the best vision. And it's critical to screen for things like Demodex blepharitis, as well as treating comorbid coinciding conditions such as glaucoma, retinal diseases, and corneal abnormalities, including corneal nerve function. So let's get a score update. Oh, it's a tie. We're pretty competitive here. And so we don't like ties in Intrepid. So we're going to move on to our speed round here. This is a little different. So we're going to move into a speed round. This is our communication challenge, proving that not only can we be good at answering board exam questions, but can we communicate with patients. So this is the communication lightning round. There will be a video from a real patient you might recognize. Whoever buzzes in first gets to respond to this patient. Take the lead here if you can. Patient number 1.
Hi, so I've been told that I can get rid of my reading glasses and I'll never have to wear them again, right? If I pay this extra money, then I can have the surgery and I'll never have to look like my grandma with this ever again, right? My doctor said that it's the coolest thing and I don't want to have to wear these. So I know they said something about maybe being the less dependent on your glasses, but that's just something people say, right? That's not a real thing. If I pay all this money, then I am not gonna wear these glasses.
All right, we've got a buzz over there from Carolyn. I have to ask first, Selena, do blondes have more fun?
Yes, they do.
Trinity exercise studio on
Yeah.
your slide.
So I have to tell like a tiny story. So did you know this lipstick on my teeth? I did that on purpose. But I had my 13-year-old film this, and she was horrified. She's like, "This is going where, and who's going to watch this? I can't even film this, Mom. It's so bad."
So yes, we'll add Trinity exercise to your disclosure slide. We'll get you some dye here later. As Carolyn says, blondes do have more fun.
Well, first of all, the glasses look beautiful on you.
What's really sad is this is a pair of glasses I had when I was 22. These used to be in style. Used to be.
All right, Carolyn, how would you communicate with this patient?
Yeah, I think it's really important to set realistic expectations. So reducing the need or the dependence for wearing glasses, but certainly we cannot eliminate the need for glasses entirely.
I love it. Team 2, back in the lead. All right, Team 2. Jazz Cats, back in the lead with the buzz and a correct answer. A great discussion of patient number 1. How about patient number 2? Here we go.
Doc, are you tripping? That seems so expensive. Why should I invest in those presbyopia treatment options that you be recommending?
All right, patient 2, we've got a buzz.
I want those glasses. And that hair.
Rendered him speechless.
All right, this seems very expensive. Why should I invest in presbyopia treatment options? How would you communicate with that patient, Justin? You're really taken back by this guy, aren't you?
I was not expecting that. I haven't seen these videos. That I was not expecting. So I think you need motivated patients. I think when you're talking about cost around this, I always ask a simple question. I always say, are you interested in reducing your dependence on glasses? And if it's a patient that tells me no, I'm not going to sell them a technology. Some of the most unhappiest patients are the ones that you sell the technology to. That's not my job to sell it. My job is to educate. My job is to offer them options. The happiest patients are the motivated ones, the ones that are educated and they understand it's not going to fix all of it. So I always think about a motivated patient. A motivated patient's going to do well. I'm not a salesman. That's not my job.
Points awarded. Fighting Iris has tied it up. How about patient number 3?
Hello, distinguished panel. My name is Julius, and I found all of these options on the internet. How am I supposed to go through all of them? Please tell me the pros and cons.
All right, we got it. Selena's got it. We've got a patient here looking at all these treatments. That's such shiny hair.
I love it. I appreciate, what was his name? Jules? Julius. So I appreciate Julius and his finding of educating himself before he comes in. But we get to be the doctor. The patient doesn't get to do that. We get to drive the conversation. You can't let the patient lead, but we have to educate at the same time. So I love patients that come in because they are educated and it's a different conversation. And so for him, I'm going to walk through and ask a lot of good questions and read the room, and he's going to want to know the answers to all of those questions. But if I ask good questions, I'm going to be able to help Julius get his best optimized vision with his surgery.
Excellent answer. Fighting Iris takes the lead. All right, patient number 4.
Okay, so I think I'm finally ready for cataract surgery, and I just think I'm ready to get rid of my glasses, but I just hate halos and glare.
All right, we've got a buzz. Dr. Schaefer with
First
the
off,
glare.
I love the halo and glare in the video, right? Intentional? Intentional? Very intentional. I love it. So I love these patients because they're driving this bus, right? They are driving the cataract surgery bus, especially in a primary care clinic. So I'm excited when a patient is ready for surgery, and now we get to talk about all the great options that they're going to get to enjoy once they have the surgery. but we're going to talk about how we're going to get to that journey, right? And it's about, we needed to make sure if we want to maximize our visual outcome, what that surface looks like, and we're going to go through a process so that everything is ready, so when you come through this process, you're doing the best that you can, because she needs to live her best life.
I think she is living her
Travel the
best
world,
life.
right?
Looking at that girl.
You going to Portugal?
Just got back from Portugal. Yeah, she's living her best life. But this is a complex problem because this lady, I had this exact patient who I mimicked this after because she wanted to get rid of her glasses, but not really. She just wanted to get rid of the refractive error, but keep the big frames. And so this, I like tried to channel my inner actual patient. It reminds me a lot of this.
That's great.
That was like, I would love to wear a multifocal, but can I put clear lenses in my glasses because these are iconic for me? And I was like, yes, I can.
Sure.
You can believe that.
That's right.
That's great. That's great, Mark. And the Jazz Cataracts points to you. We've tied it up again. All right, like I said, we don't like ties here. It's time for a tiebreaker. So we need your help. As part of our audience, we want you to vote for your favorite team. No pressure here. Fighting Irises or the Jazz Cataracts. No bribing allowed. Fighting Irises or the Jazz Cataracts? Who is your favorite? Let's get you logged into your phones again. Let's get this. Take your time. This is a very critical point in the evening. There might be a lot of money on the line here behind the scenes, or at least one of the teams is going to pick up the tab tonight. But we appreciate all of you contributing to the trophy, the awards ceremony, for who is going to be the winner of Focus Feud. Oh, let's see if we can get it working. Let's see if we can reset the poll for you. Hang on. Are we working now? All right, so let's get your votes in there. Scan the QR code if you need to. We need your help. We need your vote. No voting twice, no hanging chads. This is a very official polling system, so with the lead, Jazz Cataracts takes home the trophy. Winners of Focus Feud. All right, we have a couple more things here as we close up the evening. Let's give a big round of applause for the Jazz Cataracts, as well as our second place team, the Fighting Irises. Great contributions tonight on both sides of the arena. Congratulations, Jazz Cats. All right, polling question number 8. As we asked earlier, after your experience here tonight, how confident are you in discussing the outcome expectations of refractive IOL patients and identifying the impact of unhappy refractive IOL patients on an optometric co-management practice, which you all have because you all see patients with cataracts, I assume. All right, so let's chime in with that. Very confident, confident, not so confident, not confident at all. All right, looks good here. I've shifted the bell curve here a little bit. I love it. Very confident people out there. After they saw us perform this evening, they're very confident in themselves. How confident are you in defining best practices for diagnostic key comorbid conditions in patients considering refractive IOLs, including lid management? How confident are you in those things? Great job tonight, both teams contributing, to getting the word out. All right, pre and post, very confident people out there. I love it. This is good. We've budged the needle. Polling question number 10. How confident are you in identifying and applying the best practices for interacting with your refractive IOL patients, whether they have lipstick on their teeth or glare and halos behind them, and co-managing surgeons and surgeries before and after treatment. How confident do you feel with managing these sort of things? Not necessarily the lipstick, I can't manage that, and I definitely can't manage hair. It's not a strength. But very confident, very good. I love seeing this. Poll number 20. Great job, everyone. I'm glad you're very confident or confident. Number 11. How significantly do you believe what you have learned at this symposium has improved your ability to optimize refractive IOL patient satisfaction? How do you believe the symposium has improved your ability to optimize patient satisfaction? Awesome. Looking good. All right. Again, I want to thank our grant supporters so we can do fun things like this, educate, entertain. Horizon, J&J Vision, and Tarsus. We'll be around here to answer any questions or discuss this further. Enjoy your evenings, enjoy your academy. Thank you all for attending and participating in this experience, and I hope you found it fun and exciting.
Thank you.
You'll be emailed a link for your COPE credits within 24 hours. And again, round of applause for our teams here. Hosted by me, Jacob Lang. I hear we want to hug it out here and make sure there's no hard feelings.